Good morning. It's 4:28, as you can see. We're on time. Slept late actually. I'd gone out for dinner. So I came back at like 10, 10:15. I slept very late. And okay, I'll have to come home and compensate. I always say that and I never end up. But yeah, it's okay. I should definitely compensate after coming home. कल का schedule भी आया है. Like आज का. Let's follow that. Good morning, MS, Sarthak, Sakshi, Shambhavi, and Ansh. Oh, nine, a few others. So proud. Everyone's woken up. Hello, Sahil. Oh, Sahil. Hi. Sahil is my batchmate. We're in the same practical group, same uh, physics ka group also. Physics practical and that practical. What time do you sleep? I try to sleep by 9:30. Don't end up sleeping always. Hi, Kriti. Don't always end up sleeping at that time, but I try. How do I increase my eyes? Because I keep getting distracted. Well, I mostly keep streaming for like really long, so you can just join me. And then when you're streaming with me, don't do any time pass. Tomorrow's time 17 hours speed run. नहीं नहीं भाई इतना इतना भी एनर्जी नहीं है. I'll try as much. I don't know 17 hours तो नहीं लग रहा. I want to take it like I don't want to overwork myself. I don't know how much. Okay, so let's start. I'll also get things ready. No, that also I don't know. Maybe. Adam, yeah. I'll just get everything ready. Uh, I haven't kept anything ready, food and all. Okay, we'll take a break at. It's currently what 4:30. 4:32. So we'll take a break at say 6 a.m. You can all put your targets till then. So let's put our targets. I will finish with protein metabolism. Now, but I'll finish adrenal cortex. This is too long. It's been going. Then I'll finish adrenal medulla and start neurophysio. Let's go. I'll just be back. चल स्टार्ट 40 ठीक. ACTH stimulation test. It is also called cosintropin or tetracotrazine test. Cosintropin or tetracotrazine test is ACTH stimulation test. Oh. Cosintropin test. The stimulation test, ACTH stimulation test. You give that and then you keep it for 1 hour. In a complete day, you measure the levels of cosintropin or synactin. Synactin or cosintropin. Patients that didn't cortical damage or destruction will not show increase in serum cortisol secretion to ACTH. Addison's disease, the prolonged is used to differentiate between primary and secondary causes of adrenal insufficiency. Okay, prolonged ACTH is for what? Primary and secondary. And the short term is for to check whether the adrenals are working properly. मतलब ACTH से signal आ रहा है but adrenal से नहीं जा रहा है. Now corticotropin releasing hormones administered typically in normal individuals ACTH secreted by the pituitary in 60 to 80 minutes is specific to testing the pituitary function. This can test the Cushing's syndrome, adrenal cortex tumor, or the Cushing's disease that is pituitary dependent. Oh, Cushing's syndrome is adrenal cortex tumor, and Cushing's disease is pituitary dependent. Oh, okay. Cushing's disease is pituitary. Uh, Cushing's disease is Cushing's is pituitary. Cushing's disease is pituitary dependent. Is to evaluate the adrenocortical hypofunction or hyperfunction. So you are basically checking the pituitary function. Now, next is insulin-induced hypoglycemia stimulation test. Insulin is given to subject in a patient to induce hypoglycemia. In this, in turn, stimulates the release of CRH by the hypothalamus. Concentrations of ACTH and cortisol are measured. To evaluate the hypothalamic pituitary adrenocortical axis (HPA axis), cautions to be taken since the test involves inducing hypoglycemia should be avoided with patients with heart disease and seizures. Now, metirapone stimulation test. We know metirapone is a steroidogenesis blocker. Metirapone, ketoconazole, and come on, I know this. I've done this a billion times. Metirapone, ketoconazole, and aminoglutathione. Oh my god! Finally, is a substance that converts the 11 beta hydroxylase enzyme. It inhibits the 11 beta hydroxylase enzymes that catalyzes the conversion of 11 deoxycortisol to cortisol. So it is an 11 beta hydroxylase inhibitor, 11 beta hydroxylase inhibitor, which causes 11 dehydrocortisol to become cortisol. By inhibiting the production of cortisol, the negative feedback loop is reduced. Yes, sir, inhibiting the production of cortisol. And also that catalyze the conversion. So 11 deoxycortisol is measured. That is called metarapone stimulation test. 11 deoxycortisol measured. This is an indirect test for hypothalamic pituitary adrenocortical axis. The test is used to evaluate Cushing's syndrome or Cushing's disease, not advised for Addison's syndrome to worsen the condition. हाँ एडिसन्स में वैसे भी कम है, तो और भी कम तो कैसे है? डेक्सामिथाजोन is a synthetic steroid compound is admitted and low to suppress or reduce ACTH secretion from the pituitary. Dexamethasone is used to suppress or reduce the amount of ACTH secretion from the pituitary. This will reduce the cortisol production by the adrenals, urinary, and serum. Cortisol levels are measured in the test. So you're reducing the cortisol production by the adrenals. So the drug is administered in low doses to suppress or reduce ACTH secretion from the pituitary. Hmm. Reduce or suppress the amount of ACTH secretion. So dexamethasone reduces or suppresses ACTH from the pituitary. This will reduce cortisol level. Okay, okay, no thoughts. Focus. The set of reduced urinary and serum cortisol levels are measured. It's used to evaluate the hypothalamic pituitary adrenocortical axis. User diagnosis of Cushing's disease, adrenal tumor, side effect of the production of ACTH as well. Dexamethasone test that is inhibits the reduction of secretion of ACTH from the pituitary, and again HPA axis hypothalamic pituitary axis को evaluate करता है. Adrenocortical axis hypothalamic pituitary adrenocortical axis. ठीक. Next we have mineralocorticoid suppression test. Mineralocorticoid suppression test. So dexamethasone, mineralocorticoid, adrenal androgen, and adrenal androgen suppression test. Stimulation and adrenal androgen suppression test. So first we have mineralocorticoid suppression test. The test I used to evaluate the adrenal aldosterone secretion or renin-angiotensin aldosterone system. You can either do saline suppression test or fludrocortisone suppression test. You can do saline suppression or fludrocortisone suppression test. These tests are useful to diagnose primary hyperaldosteronism, primary hyperaldosteronism, or conditions where patients may have tumors which secrete aldosterone, tumor secreting aldosterone, hyperaldosteronism, or uh, you can use fluorocortisone test, fludrocortisone test, or saline suppression or fludrocortisone test. Fine. So this adrenal androgen test. Next we'll go to adrenal androgen stimulation test. Again, it is a plasma dehydroepiandrosterone. ACTH will increase DHA and androstenedione up to fourfold in 90 minutes. May not be considered valuable in diagnosing hypoandrogenic conditions. Adrenal androgen suppression tests. The synthetic steroid dexamethasone is used to suppress adrenal androgen production. So adrenal, the system synthetic steroid dexamethasone is used to suppress adrenal androgen production. So here dexamethasone suppressing adrenal androgen. Two types of tests are done: short dexamethasone androgen suppression test, that is 4 hours, and long dexamethasone androgen suppression test. Short and long dexamethasone. It is used to suppress androgen and adrenal androgen. So dexamethasone decreases adrenal androgen production. Dexamethasone decreases the adrenal androgen. Dexamethasone suppresses adrenal androgenic function. Dexamethasone suppresses adrenal androgen. And the androgen excess. It will be made a diagnosis of adrenal tumors secreting excess androgens, Cushing's syndrome, and polycystic ovarian syndrome (PCOS). Polycystic ovary syndrome (PCOS). ठीक. Finally, bro. Cortex done. Let's go. Good going, good going. Okay. Cortex done. Calcium homeostasis done. Adrenal cortex done. Now adrenal medulla. I will time every page and I will finish fast. Let's go. Right, we will time every page. Also, guys, we reached 900. I'm so happy. We're at 911. So, thank you, everyone. Uh, Okay, this is adrenal medulla. I think I should tell the break. Adrenal medulla is how many? 1, 2, 3, 4, 5, and 6 pages. So, chalo, uh, before 6 o'clock, I will finish adrenal medulla no matter what. And we're going to time every page. Let's go. I love adrenal medulla. It's what catecholamines or कुछ नहीं. ठीक. Catecholamines are amines that are derived from the substance catechol, include epinephrine, norepinephrine, and dopamine. Pheochromocytoma are tumors that arise from chromaffin cells that secrete catecholamines. Pheochromocytoma arise from chromaffin cells that secrete the adrenaline, catecholamines. Chromaffin cells secrete uh, catecholamines, and pheochromocytoma is a condition where there is tumor of these chromaffin cells. Pheochromocytoma, tumor of the cortical cells, adrenal medullary cells called chromaffin cells, adrenal medullary cells called chromaffin cells, which will secrete excess uh, catecholamines now. Sympathetic tone is the basal rate of sympathetic activity that is continual. The adrenal medulla occupies the 20% of the adrenal gland and is functionally related to the sympathetic nervous system. It secretes the hormone epinephrine and norepinephrine respond to hormone stimulation. Sympathetic nerve. Interatromedial hall, that is IML. Through the sympathetic chain through the splanchnic nerves. So IML so either you have horn cells, the spinal cord, or the intermediolateral horn cells. Oh, they go to the sympathetic chain. So sympathetic chain, we know, we've seen it. Then that goes to the splanchnic nerves. And then it reaches adrenal medulla. Okay, so IML goes to sympathetic chain goes to splanchnic nerves, and that goes to the adrenal medulla. Intermediolateral horn cells, the spinal cord goes to sympathetic chain goes to the sympathetic chain goes to what? Splanchnic nerves will reach up the adrenal medulla. So it's very fast. They that they end directly on modified neuronal cells that secrete epinephrine and norepinephrine into the bloodstream. These secretory cells embryologically derived from nervous tissue and actually postganglionic neurons. Indeed. Oh, really? The postganglion. Indeed, they have rudimentary. They even have rudimentary nerve fibers. It is the endings of these nerve fibers that secrete the adrenal hormones. So the cells are only like the embryologically the nervous tissue cells, and the endings of these will only secrete apna norepinephrine and epinephrine. Fine. Epinephrine and norepinephrine. Now, biosynthesis of epinephrine, norepinephrine, its removal and duration. Biosynthesis of epinephrine, norepinephrine, its synthesis and duration, removal and its duration of action. Sympathetic. I'll just do that in between. If anyone's not studying, please study again. Biosynthesis of epinephrine, norepinephrine, removal and duration of action. Synthesis of norepinephrine begins in the exoplasm of terminal nerve endings of adrenergic nerve fibers. So is being synthesized norepinephrine in the exoplasm. Okay. Axon का cytoplasm of terminal nerve endings of adrenergic nerve fibers. Exoplasm of the terminal nerve endings of adrenergic nerve fibers. Okay. Exoplasm of terminal nerve endings of adrenergic nerve fibers. It is completed inside the secretory vesicles. Okay, it's completed inside secretory vesicles, and it begins. Synthesis will begin in the exoplasm in the terminal nerve endings and adrenergic nerve fibers. Terminal nerve endings and adrenergic nerve fibers. So terminal nerve endings and adrenergic nerve fibers. After secretion of norepinephrine by the terminal nerve endings, it is removed from the secretory site in three ways. So once you're secreting norepinephrine, it is removed from the secretory, reuptake by into the adrenaline nerve endings by an active transport process, accounting for removal of 50 to 80%. So your same adrenaline nerve fibers are taken up by an active transport. So that is 50 to 80% is being removed like that into the same active transport process. Same in the active transport process, reuptake. ठीक. So 50 to 80% of the secreted norepinephrine and reuptake by active transport, accounting for removal of 50 to 80% of the secreted norepinephrine. ठीक, 50% निकाल दिया. Now diffusion away from the nerve endings into the surrounding body fluids and then into the blood. Removal of most of the remaining norepinephrine. So diffusion basically. First is reuptake by active transport, second is diffusion, and third is destruction by small amounts by tissue enzymes. One of these enzymes is called monoamine oxidase, which is found in nerve endings and another is cortical O methyl transferase, which is present diffusely in the tissues. So nerve endings may we have monoamine oxidase, and in the tissues we have catechol O methyl transferase, and uh, what was that? Monoamine oxidase. Monoamine oxidase in the nerve endings. Monoamine oxidase in the nerve endings. Monoamine oxidase. Monoamine oxidase in nerve endings and okay, so we have monoamine oxidase in the nerve endings and catechol O methyl, no, catechol O methyl transferase and diffusion in the tissues. Ordinary norepinephrine secreted directly into a tissue remains active only for a few days, few seconds, demonstrating that reuptake and diffusion away from the tissue are rapid. However, norepinephrine and epinephrine secreted into the blood by adrenal medulla remain active until they diffuse into some tissue where they can be destroyed by catechol-O methyltransferase. This action mainly occurs in the liver. Therefore, when secreted into the blood, both epinephrine and norepinephrine remain active for 10 to 30 seconds with activity declines to extinction over 1 minute to several minutes. So remain active for 10 to 30 seconds. Factors that control the secretion of catecholamines from the adrenal medulla. What controls the secretion of catecholamines? ठीक है. Several stressful stimuli can activate the catecholamines stimulation from adrenal medulla. Mm. Stressful stimuli can activate it. One is position of the individual, that is standing increases norepinephrine secretion. Really? Okay. Posture, standing will increase norepinephrine. हाँ मतलब correct. Standing, then less blood pressure, less cardiac output. So then वैसे we can say कि decrease होगा. Fine. Now is exercise. Varying degrees of exercise can cause catecholamine secretions. Varying degrees of exercise can cause catecholamine secretion. Varying degrees of exercise. So varying degrees of exercise can cause catecholamine secretions. Hypoglycemia, that is strongly stimulates epinephrine. Cigarette smoking, ठीक है. Catecholamine goes increases by cigarette smoking, hypoglycemia, exercise, surgery, both epinephrine and norepinephrine, ketoacidosis. Ketoacidosis will cause epinephrine and norepinephrine. Myocardial infarction and anesthesia. Surgery, anesthesia, ketoacidosis, cigarette smoking, hypoglycemia, exercise, and position of the individual. The chromatin cells in the adrenal medulla are stimulated by the acetylcholine released from the preganglionic sympathetic fibers. Abhi, I'm already at 11 minutes on my fast. Not the medulla is made by the acetylcholine released from preganglionic nerve fibers. These chromatin cells have nicotinic cholinergic receptors and depolarize on contact with acetylcholine. Activation of voltage-gated calcium channels. So nicotinic cholinergic receptors, acetylcholine, voltage-gated calcium channels to open up. This result of this activation causes the release of vesicle contents by a process of exocytosis into the extracellular space. The release of norepinephrine is controlled by the activation of alpha 2 receptors that are located on the presynaptic membrane. Alpha 2 receptors on the presynaptic membrane. The stimulation of these receptors inhibits the release of norepinephrine. Stimulation of receptors will inhibit the release of norepinephrine. So your activation of alpha 2 receptors. Alpha 2 receptors are located on the presynaptic membrane. Presynaptic membrane. Stimulation will inhibit the release of norepinephrine. Clonidine is used to treat hypertension. Hypertension. Clonidine is used to treat hypertension. God, we took 13 minutes for an easy page. Not done. Absolutely not done. Go faster. But okay, ठीक है, चलो, we can do it. These are the catecholamine biosynthesis metabolism synthesized steps. Synthetic steps are shaded orange. Degenerative steps are shaded turquoise. Major catecholamines are given in green. Major metabolites in yellow. So we have tyrosine. Tyrosine in the presence of tyrosine hydroxylase. So you have tyrosine, that is an alpha amino acid. The CH2, like it's like phenylalanine and then an OH, correct? Phenylalanine. Tyrosine hydroxylase becomes dihydroxyalanine, L dopa. Dihydroxyphenylalanine. There's L dopa. Dihydroxyphenylalanine. L dopa. Now in the presence of dopa decarboxylase. I remember this. So you have tyrosine becoming dopa, dopa becoming dopa decarboxylase, dopa decarboxylase becomes dopamine. That is dihydroxyphenylalanine. Dihydroxyphenylalanine. This is called tyrosine hydroxylase. Tyrosine hydroxylase. So tyrosine in the presence of tyrosine hydroxylase will form L dopa. L dopa in the presence of dopa decarboxylase. Dopa decarboxylase will form dopamine. Dopamine will form two products. So first, it will form in the presence of dopamine beta hydroxylase. Dopamine beta hydroxylase. It forms norepinephrine. That forms epinephrine. In the presence of phenylethanolamine and methyl transferase. Phenylethanolamine and methyl transferase. Now norepinephrine becomes my god, nor normetanephrine, and it can also form 3,4 dihydroxymandelic acid. And epinephrine can also form this, but epinephrine can also form metanephrine. And all of them will ultimately cause the formation of VMA, vanillyl mandelic acid. VMA, vanillyl mandelic acid. So you have tyrosine. Tyrosine becomes L-dopa in the presence of tyrosine hydroxylase, which is dihydroxyphenylalanine. You have dihydroxyphenylalanine. So tyrosine is becoming L-dopa. Dopa in the presence of dopa decarboxylase. So tyrosine hydroxylase, dopa decarboxylase becomes dopamine. Dopamine becomes norepinephrine in the presence of dopamine beta hydroxylase. Epinephrine in the presence of phenylethanolamine and methyl transferase. This is dopamine beta hydroxylase. So beta OH pairs hydrolyzing it. Fine, easy. And now you have phenylethanolamine. Phenylethanolamine and methyl transferase. Ethanolamine. Damn. So you're getting a nitrogen and then NCH3. You're getting an NCH3 that is called epinephrine. So norepinephrine becomes epinephrine, that is phenyl. Thick, I got it. Phenyl ethanolamine and methyl transferase. Norepinephrine in the presence of monoamine oxidase. Monoamine oxidase is present naturally in the somewhere it's present naturally in catechol or methyl transferase is naturally present in tissues, and monoamine oxidase is present. I just read it in nerve endings. Correct. Catechol O methyl transferase from epinephrine forms metanephrine, and metanephrine is of course an important metabolite. Okay. And you have vanillyl mandelic acid being produced. So you have epinephrine, norepinephrine. Epinephrine becomes, in the catechol O methyl transferase becomes metanephrine and 3,4 dihydroxy mandelic acid. 3,4 dihydroxy mandelic acid and metanephrine. Norepinephrine becomes normetanephrine and 3,4 dihydroxy mandelic acid. Norepinephrine in the presence of monoamine oxidase becomes 3,4 dihydroxy mandelic acid. Monoamine oxidase, both in both places. Monoamine oxidase here and here. So monoamine oxidase in the presence of epinephrine, norepinephrine from 3,4 dihydroxy mandelic acid. I'll just be back. 3,4 dihydroxy mandelic acid. We have tyrosine hydroxylase, L hmm. uh, L-dopa, that is dihydroxyphenylalanine, dopa decarboxylase, and the process becomes dopamine. Tyrosine L-dopa, dopamine. Dopamine is by dopamine beta hydroxylase norepinephrine. Norepinephrine because of phenylethanol amine and methyl transferase becomes norepinephrine. Epinephrine. Epinephrine with the catechol O methyl transferase becomes metanephrine. And norepinephrine in the presence of catechol O methyl transferase becomes normetanephrine. Oh, nice. This catechol O methyl transferine is present in the tissues itself. When you have monoamine oxidase, that is monoamine oxidase will form 3,4-dihydroxymandelic acid, also formed from epinephrine by monoamine oxidase. Now this again will by monoamine oxidase, MAO also forms vanillyl mandelic acid. This also by monoamine oxidase forms and this is catechol O methyl transferase. Okay, I don't think I need to know it in detail, but I got an idea. Now, adrenergic receptors, that is alpha and beta. The two major classes of adrenergic receptors exist. They are called alpha and beta receptors. There are two major types of alpha receptors, alpha 1 and alpha 2, which are linked to different G proteins. Alpha 1 and alpha 2 are linked to different G protein coupled receptors. Okay. That beta receptor, beta 1, beta 2, beta 3, because certain chemicals affect only certain beta receptors. They also use G proteins. Norepinephrine, both of which are secreted only by the adrenal medulla, slightly different effects in exciting the alpha and beta receptors. Norepinephrine excites mainly alpha receptors, but excites the beta receptors to a lesser extent. So norepinephrine excites mainly alpha receptors, but norepinephrine will excite the alpha, but excites the beta receptors to much lesser extent. So norepinephrine mainly causes for alpha receptors, but beta receptors के लिए कम है. ठीक है, let's go ahead. Next we have alpha receptors causes vasoconstriction, iris dilation, intestinal relaxation, intestinal sphincter contraction, muscle relaxation, and sphincter will get contracted. Correct. Pilomotor contraction, yes. Bladder sphincter contraction means it will close basically. Inhibits the neurotransmitter release. Alpha 2 inhibits the neurotransmitter release. Beta receptor will cause vasodilation, cardio acceleration. Beta 1 causes cardio acceleration, but it still causes vasodilation. Increased myocardial strength. Okay. Beta causes vasodilation, but it still causes cardio acceleration and increased myocardial strength. You have intestinal relaxation, uterus relaxation, bronchodilation, calorie glycogenolysis, lipolysis, bladder wall relaxation, and thermogenesis. 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 ठीक है, thermogenesis. Thermogenesis. So your epinephrine, which is exciting both types of receptors approximately equally. Array, okay, beta intestinal relaxation, uterus relaxation, bronchodilation, calorigenesis, glycogenolysis, lipolysis, bladder wall relaxation, and thermogenesis. Epinephrine excites both types of receptors approximately equally. Therefore, the relative effects of norepinephrine and epinephrine different on different effector organs are determined by the type of receptors in the organs. If they are all beta receptors, epinephrine will be more effective excitant. Correct. 92.1 lists the epinephrine alpha and beta and some other organ and systems controlled by sympathetic nerves. Note that alpha functions are excitatory whereas others are inhibitory. Likewise, certain beta functions, therefore, alpha beta receptors are not necessarily associated with excitation or inhibition, but simply with the affinity of the hormone for the receptors in the given effector organ. A synthetic hormone, chemically similar to epinephrine and norepinephrine, called isopropyl norepinephrine, has extremely strong action but on beta but no action on alpha. Isopropyl norepinephrine, isopropyl norepinephrine has a strong action on beta receptors but no action on alpha. Isopropyl norepinephrine strong action on beta but no action on alpha. Isopropyl norepinephrine beta पे है strong action, alpha no reaction. Now physiological effects of catecholamines. Physiological effects are excitatory and inhibitory actions of sympathetic stimulation. ठीक है, excitatory inhibitory stimulation, adrenal medullae. Excited reaction sympathetic change lists the different types of visceral functions caused by stimulating sympathetic organ. Sympathetic causes excitatory effects in some organs but inhibitory effects in the other organs. Now the functions of the adrenal medulla. Mm, Function of adrenal medulla is the stimulation of sympathetic nerves to the adrenal medulla. Stimulation of sympathetic to the adrenal medulla causes large quantities of norepinephrine and epinephrine to be released. Mm. Adrenal medulla causes large quantities of epinephrine and norepinephrine to be released into the circulating mass. These two hormones are carried in the blood to almost all tissues in the body. 80% of the secretion is epinephrine, 20% is norepinephrine, although the relative proportion can change as well as physiological condition. And the circulating epinephrine has almost the same effects on different organs as the effects caused by direct sympathetic stimulation, except that the effects last 5 to 10 times as long because both the hormones are removed from the blood slowly over a period of 2 to 4 minutes. Oh, so nerve stimulation say they last longer because they are removed from the blood slowly. The circulating norepinephrine causes constriction of most of the blood vessels of the body. It also causes increased activity of the heart, inhibition of gastrointestinal tract, dilation of pupils of the eyes, and so forth. So eyes will be dilated, pupil, ciliary muscles will be slight relaxed for far vision. Oh, slightly relaxed. Ciliary muscles will be slightly relaxed for far vision. Glands are vasoconstriction and slight secretion. Nasal, lacrimal, parotid, submandibular, gastric, pancreatic, sweat glands. Hmm. Copious sweating. Apocrine glands are thick odoriferous secretion, mostly constricted. Heart muscle में increased rate decreases the force of contraction. Really? Coronaries are dilated in beta 2 and constricted in alpha 2. Coronaries are dilated by beta 2 and constricted by alpha. So alpha, beta. Increased force, you have coronaries like dilated, which is beta, and constricted alpha 2, alpha. And muscle increased force of contraction means decreased force of contraction by the atria. Decreased force of contraction by the atria. Decreased force of contraction by the atria mostly. Especially decreased force of contraction by the atria, especially the atria. Now, lungs, that is bronchi, are dilated, blood vessels are mildly constricted, gut lumen decreased peristalsis and tone, sphincter increased tone, liver glucose is released, gallbladders and bile relaxed. Decreased urine output and increased renin secretion. Bladder, you have detrusor muscle which is relaxed and the trigone muscle which is contracted. Bladder, detrusor and trigone. Detrusor is relaxed and trigone is contracted. Trigone is contracted and detrusor is relaxed. Penis ejaculation, systemic arterioles, abdominal viscera muscles. इसमें ejaculation होगा ना. Systemic arterioles में abdominal viscera are constricted. Muscles में adrenergic alpha will cause constriction and dilation by beta and adrenergic B2. Skin is constricted. Blood coagulation is increased in the blood. Glucose increase, lipids increase, basal metabolism increase, adrenal medullary secretion increase, mental activity increase, piloerector muscles contracted, skeletal muscle increase, glycogenolysis and increased strength and fat cells में lipolysis को रखो. Epinephrine causes almost all the same effects as those caused by norepinephrine. But the effects differ in the following respects. Epinephrine, because of greater effect of stimulating the beta receptors, has a greater effect on the cardiac stimulation than does norepinephrine. Second, epinephrine causes only weak constriction of blood vessel in muscles. Much stronger constriction caused by norepinephrine. So epinephrine causes a weak contraction in the muscles, but norepinephrine causes a much stronger contraction. Norepinephrine, much stronger contraction in the muscles. Norepinephrine causes a much stronger contraction in the blood vessels. Epinephrine will only cause a weak constriction of the blood vessels. Okay. In comparison with the much stronger blood vessels caused by norepinephrine, because the muscle vessels represent a major segment of the vessels of the body. Differences are special importance. Norepinephrine greatly increases the total. It will elevate the arterial partial pressure. Epinephrine causes the raise the arterial pressure less extreme extends the cardiac output more. Epinephrine increases the cardiac output more. The difference between action of she had took 14 minutes. Chala yaar, faster. A third difference between the action of epinephrine and norepinephrine relates to the effects on the tissue metabolism. Epinephrine has 5 to 10 times the greater metabolic effect on as norepinephrine. Indeed, the epinephrine secreted by the adrenal medulla can increase the metabolic rate of the whole body as much as 100%. In this way, increasing the excitability and activity of the body. It also increases the rate of other metabolic activities, glycogen lysis in the liver, and the glucose release into the blood. Glycogen lysis in the liver and muscle and glucose release into the blood. In summary, stimulation of adrenaline causes the release of which will have one of the same effects to the body as direct stimulation affects the effects. 2 to 4 minutes after this. Mm, Myocardial relaxation. It's called lucitropy. How many have we reached now? Nice, 9, 1, 3. Okay. So epinephrine. Now, what is sympathetic tone? We have one, two. Come on, I can finish. Sympathetic tone, fine. Mm. Normally, the sympathetic and parasympathetic systems are continually active. Sympathetic and parasympathetic systems are continually active, and the basal rates are known, respectively as sympathetic and parasympathetic tone. And the value of tone is that it allows a single nervous system to both increase and decrease the activity of a stimulated organ. Hmm. Tone allows a single nervous system to both increase and decrease the activity of stimulated organ. This normally keeps all the system. Much of the overall tone Much of the overall tone of the sympathetic nervous system results from the basal secretion of epinephrine. Alarm or stress response of the sympathetic nervous system. Large portions of sympathetic nervous system discharge at the same time. That is called a mass discharge. So when a large portion of sympathetic system are discharging at the same time, called mass discharge. This increases the ability of the body to perform a vigorous muscle activity. Many ways summarized in the following list. Increase arterial pressure, increase blood flow to the active muscles concurrently. When large portion of synthetic nervous system discharge at the same time, that's called mass discharge. The action increases the ability of the body to blood flow to the muscles active concurrent and decrease blood flow to organs such as the GIT and kidneys that are not needed for rapid increase in the cellular metabolism, increased blood glucose concentration, increased glycolysis in the liver and muscles, increased muscle strength, increased mental activity. So muscle strength बढ़ा, mental activity बढ़ा, rate of blood coagulation बढ़ा. Why do we need to increase blood coagulation? The sum of these effects will permit a person. Some of these effects will permit a person to perform far more strenuous physical activity than would otherwise be possible. Within the reticular formation of brainstem. Most aforementioned sympathetic events ensue immediately. That is called sympathetic alarm reaction. It's called fight or flight reaction because an animal in this state decides almost instantly. In either cases, the sympathetic alarm reaction makes the animal's subsequent activities vigorous. Now, pheochromocytoma means we saw that chromaffin cells are affected and they are excessively stimulated. That tumors that arise from the chromaffin cells that secrete catecholamines, about 90%. So, pheochromocytoma are tumors of the chromaffin cells that will secrete the catecholamines. Pheochromocytoma Pheochromocytoma. It's a cancer, that will secrete what? It's a chromaffin tumor. And that will mostly cause more secretion of noradrenalines and catecholamines. 90% occur in the medulla. However, occasionally they rise on the abdominal sympathetic ganglia. Inferior mesenteric artery or abdominal sympathetic ganglia close to the aorta. When they occur in the sympathetic ganglia, they are referred to as catecholamine secreting paragangliomas. अगर सिंपैथेटिक गैंग्लिया में हुआ तो पैरा कैटेकोलामिन सिक्रीटिंग पैरा गैंग्लियोनिक गैंग्लियोमा. So you have pheochromocytoma, which is a tumor that is arising from the chromatin cells that secretes catecholamines. Most of them are obviously in the adrenal medulla. 10% can be in the peripheral, that is abdominal something, abdominal ganglia, sympathetic ganglia close to aorta or the inferior mesenteric artery. Inferior mesenteric artery when they occur in the sympathetic ganglia, and then they are called as catecholamine secreting uh, paraganglioma. अरे यार. The chromaffin reaction, which occurs in the tumor tissue of adrenals, involves a color change when reacting with the salts of chromate. Pheochromocytoma. Oh, the chromaffin reaction, which occurs in the tumor tissue, causes a color change when reacting with salts of chromate. So, chromate के साथ when it reacts, that chromaffin reaction will cause a color change. This reaction is caused by the oxidation of catecholamines has been utilized. So it causes oxidation of catecholamines. Oxidation of catecholamines to diagnose pheochromocytoma. The term is derived from the Greek word pheos, meaning dusky. Pheos means dusky. Chroma means color, and cytoma means tumor. Dusky colored. Nevertheless, there is autopsy लिया तो tumors undergoes a transformation, color turning brown. The composition of Muller's solution is potassium dichromate, sodium sulfate, and distilled water, and is okay. So pheochromocytoma mein what is there? There's a chromaffin reaction, and that will cause a color change in the chromate, and because of oxidation of catecholamines. Pheos means dusky, and if we take the autopsy, then the tumors undergoes a transformation, becomes brown in color, and we use Muller's solution. Muller's solution is potassium dichromate K2CR2O7 plus sodium sulfate Na2SO4 and water. This is called Muller's solution. Mueller solution K2CR2O7 plus H2O plus Na2SO4, and there's a color change to brown. Okay. Clinical features, they are rare. So clinical features may we know that pheochromocytomas are rare. However, the occurrence is equal in male and female. Okay, it's rare, but its occurrence is Pheochromocytoma. Adrenal medulla chromaffin cells ट्यूबर ऑक्सीडेशन ब्राउन कलर बस हो गया. Now, what are the clinical features? It's equal in male and female. If they occur in children, they may be associated with hereditary syndromes with multifocal manifestation. Diagnosis of this condition is usually made in the fourth or fifth decade of life. About 90% in the fourth or fifth decade of life. Fourth or fifth decade of life. Fourth or fifth decade of life. So, in the fourth or fifth decade of life, we have hereditary syndromes with multifocal manifestation. The diagnosis is usually made in the fourth or fifth decade. About 90% of the pheochromocytomas occur as isolated unilateral adrenal medullary tumors that are encapsulated. 90% occur as isolated unilateral adrenal medullary tumors. Isolated unilateral adrenal medullary tumors. Isolated unilateral. ओके एक साइड पे ही रहता है ट्यूमर रहता है इक्वल इन मेल एंड फीमेल होता है बट चिल्ड्रन में इट कैन हैव लॉट ऑफ मैनिफेस्टेशन. Approximately 10% of the tumors are malignant. Okay, and 10% are found in tissues or glands outside the adrenal gland. Like we saw that. It can be in the abdominal ganglionic sympathetic ganglions or in the inferior mesenteric artery close to the aorta, the abdominal sympathetic ganglia close to the aorta or the inferior mesenteric artery 10% and 90% in the adrenal medulla, of course. But only 10% are malignant, so mostly benign tumor hai. So not that harmful, but still of course harmful to hai. But it's not, only 10% can metastasize because only 10% is malignant. ठीक. And rest 90, where is green? Green. अरे, my highlighters just disappear sometimes. हाँ यार, 10%. 10% of these tumors are malignant. The most common feature is the hypertension due to increased levels of catecholamines in the blood. Hypertension due to excess levels of catecholamine in the blood. ठीक है. Hypertension due to excess amounts of catecholamine in the blood. Catecholamine ज़्यादा होंगे तो more hypertension. Maybe sustained or may occur spells or paroxysms. What is paroxysms? Paroxysms, a sudden attack or outburst. Oh. Now, clinical features of diagnostic tests of pheochromocytoma including medullary function test. Diagnostic test for pheochromocytomas including adrenal medullary function test. Patients who have hyperadrenergic spells of palpitations, diaphoresis, tremors, headache, and pallor, which are self-limiting. Diagnostic test for pheochromocytoma. ठीक है. Pheochromocytoma. Diagnostic tests including adrenal medullary function test. People who have adrenergic spells or palpitations. Pheochromocytoma के लिए you can have adrenergic palpitations. ठीक है. Adrenergic palpitations. Diaphoresis, tremors, headache, and pallor, which are self-limiting. Clinical features of pheochromocytoma क्या क्या है? हाइपरटेंशन होगा, हेडेक होगा, palpitation, sense of one's own forceful heartbeat, chest and epigastric pain, Oh, wow. Excess sweating is called diaphoresis. Why didn't I not know this? Excess sweating is called diaphoresis. Diaphoresis. Excess sweating is called diaphoresis. Excess sweating, diaphoresis. Sensation of nausea or vomiting. Nausea, vomiting होगा. डायाफोरेसिस होगा. Diaphoresis. Excessive sweating, diaphoresis, nausea, vomiting, anxiety, fear of impending death. Oh, tremors, pallor. अगर क्रॉनिक होगा तो कॉन्स्टिपेशन, ऑर्थोस्टैटिक हाइपोटेंशन, रेटिनोपैथी, congestive cardiac failure, cold hands and feet, hyperglycemia, weight loss. So diaphoresis is excessive sweating. Excessive sweating. ठीक. Hyperadreneric spells of palpitations, diaphoresis, tremors, headaches, pallor. Diaphoresis, tremors, headaches, and pallor. Tremors, headaches, pallor. ठीक. Family history of cytochroma should be suspected. So, agar all these palpitations, diaphoresis, sweating, tremors, headaches are self-limiting, and hypertension is not being cured or no treatment, then that is probably a familial history of pheochromocytoma. Familial history of pheochromocytoma. Familial. Okay. So biochemical tests may you can routine biochemical tests may help in the diagnosis. Many patients manifest with hypertriglyceridemia and hyperglycemia with about 50% of glucose intolerance. So triglyceride भी बढ़ेगा because lipolysis बढ़ेगा because there are more catecholamines. There'll be hyperglycemia because of course glucose. Serum lactate dehydrogenase be elevated in some patients. LDH, serum lactate dehydrogenase may be elevated. Okay, measuring excess catecholamines or their metabolites. I just finished, guys. Just 5 minutes. I know I said break, but I'm almost done. I just want to finish. More specifically, pheochromocytoma is diagnosed by measuring excess catecholamines or their metabolites in the blood or the urine. Increased levels of fractionated metanephrines in the plasma of fractionated catecholamines and metanephrines in a 24-hour urine collection are useful tests. You check metanephrine in the plasma because we know that when you have adrenaline or epinephrine in the presence of catecholamine O transferase, catecholamine O methyl, हाँ, catecholamine amine O transferase, हाँ वही है, O methyl transferase, catecholamine O methyl transferase will form metanephrine, fine. Increased levels of fractionated metanephrines in the plasma of fractionated catecholamines and metanephrines are useful tests. More recently, with advances in the biochemical techniques, high performance liquid chromatography, HPLC, high performance liquid chromatography with electrochemical detection of tandem mass spectrometry spectroscopy. So you have high performance liquid chromatography HPLC. Hmm. Fractionated metanephrine, metanephrine, and normetanephrine. As a protocol, identification of tumors secreting catecholamines is most reliably measured by the levels of fractionated metanephrines and catecholamines in a 24-hour urine sample. Fractionated metanephrines and catecholamines, the sensitivity is 98 and specificity is 98. Okay, done. Tumors, how do you identify? By fractionated metanephrines and catecholamines in the urine in 24 hours. That's 98% sensitivity, 98% specificity. If there are strong clinical plasma fraction metanephrine should also be measured. Pharmacological tests. These tests are usually not necessary if biological tests confirm the diagnosis. So you don't need pharmacological tests then. One is the clonidine. We saw clonidine is used for hypertension. Clonidine is used for hypertension. Hypertension. Clonidine is performed if the biochemical tests in a strongly suspected patient do not reveal any changes. It's an alpha 2 agonist receptor that acts centrally and is administered orally. Clonidine is alpha 2 receptor agonist. Alpha 2 receptor agonist that acts centrally and is administered orally. Clonidine is an alpha 2 receptor agonist. Alpha 2 receptor agonist. Alpha 2 receptor agonist and acts centrally, administered orally. It has no effect on suppressing catecholamine release from the chromatin cells of Pheochromocytoma. No effect on suppressing. Oh, no effect. The suppression test should decrease the plasma norepinephrine to less than 500. What? In pheochromocytoma, the test is positive where there is no reduction in plasma. Oh, okay. Normal may it should decrease the plasma norepinephrine to less than 500. In pheochromocytoma, the test is positive where there is no reduction in the plasma norepinephrine levels even after oral dose of because it has no effect on suppressing the catecholamine release from the chromaffin cells. Oh. So it cannot suppress it from the chromaffin cells, but normally it does suppress the release of catecholamines, but it cannot suppress when there is chromaffin of the pheochromocytoma. So that makes so much sense. That's why it is a pharmacological test, clonidine suppression test. Hmm. Hmm. Only after confirmation of catecholamine excess. Okay, the importance of imaging tests that accurately locate the tumor, which will help in planning the route for surgery. Okay. Imaging tests are performed only after the confirmation of catecholamine excess. The importance of imaging are to accurately locate the tumor, which will help in surgery routes. Different modalities of imaging are used: computed tomography, magnetic resonance imaging, or 123 iodine meta iodo benzyl glutamine scintigraphy. First time I'm hearing this. It is called MIBG. How have I not heard of this? MIBG, which is called guanidine. Oh, benzyl guanidine scintigraphy. MIBG, meta-iodobenzyl G, guanidine, meta-iodobenzyl guanidine scintigraphy, MIBG. Pregnant women who is sensitive to radiation and children, ultrasound imaging is preferred. So women maybe prefer ultrasound because using sound waves, not X-rays or anything. If they diagnose early in academia, match with both medical and surgical interventions and can be cured. If it's malignant or not dead early, it could be fatal, of course.